Welcome to Let's Talk Micro.
Hello, my dear audience. Welcome to another episode of Let's Talk Micro. As always, I hope you had a great week. And of course, as always, you can find Let's Talk Micro on Apple Podcasts, Spotify, Amazon Music, GoodPods, whatever you listen to podcasts, you can find Let's Talk Micro. As far as social media, I am on Instagram, TikTok, YouTube, and Blue Sky Social as Let's Talk Micro, on X as Let's Talk Micro 1, on LinkedIn as Luis Plaza, and I have an email address which is letstalkmicro@outlook.com. So either via social media, via email, you can reach out with any feedback, any suggestions. So they are always welcome and appreciated. So please go ahead and subscribe to the podcast, download episodes, and if the app allows you to do so, please go ahead and leave a review. Thank you so much for the support. And as you know, the Let's Talk Micro podcast does not have any sponsors, so if you want to support the podcast in any way, you can do so via Venmo or via Buy Me a Coffee, KOFI, both links available on the show notes. And learning about antibiotics can be difficult, so if you are looking to learn more about antibiotics, please check out www.learnantibiotics.com and the Learn Antibiotics book available on Amazon. These resources include cheat sheets, practice tests, games, and more, and they are being used by thousands of people worldwide and may be helpful for you or your colleagues. And these are some great resources from Dr. Timothy Gauthier, a very passionate pharmacist. Okay, so today's episode is longer than normal, so I'm going to be brief, but still good content, great content actually, but I'm going to be brief, so definitely if you haven't checked out the previous episode, please go ahead and do so. And in that episode, I was joined by Emily Mathis, who's an assistant professor at Northern Michigan University, and she came to the podcast to talk about simulation lab that they designed for medical laboratory technician students. And this simulation lab that has microbiology components and also has blood bank components, it was designed to supplement the clinicals. And if maybe you work or are part of a medical laboratory sciences program, medical lab technician program, maybe you know that sometimes it is hard finding sites. And when you do, maybe they don't have all the components for the clinicals. They might be smaller labs. And this can result in a reduced exposure. The students can have a reduced exposure to different tests, and things that they're supposed to be seeing in clinicals. So with this simulation lab, they supplement their clinicals. So I think this is a great idea, and if this is something that maybe you're thinking about implementing or you need help, Emily said that she was definitely very happy to take any emails, so you can feel free to reach out to her with any questions you may have. Okay, so let me go ahead and briefly talk about today's episode, which is the next episode on the AMR series that I co-host with Andrea Princey. And if this is your first time tuning into the podcast, within the podcast, I have a series which is about antibiotics, and in this series, I am always joined by Andrea Princey as a co-host, and we basically break down antibiotics. We go over things like mechanism of action, which organisms does the drug have activity against, intrinsic resistance. We talk about the CLSI. So these are great episodes, and we are always joined by a guest. And this time was no exception, and we were joined by Sonali Kalathiya, and she's a pharmacist that right now works as a Medical Science Liaison at bioMérieux. And she came to the podcast to talk about macrolides and lincosamides. And as medical lab scientists and as microbiologists, you're familiar with these drugs. You have definitely performed a D test. You have worked with erythromycin and clindamycin. So as usual, with this type of episodes, we go over these two classes of antibiotics, we break them down, and it was definitely a great episode. And if my voice sounds different, it's because when I recorded this, that was before I was diagnosed with the flu, so I was definitely very sick that day, but I pushed through and I recorded, so that's where the difference is going to be. And one thing that has never been asked to me before was that in this episode, Sonali asked me where the idea for the Let's Talk Micro logo came from. She asked if I drew it, so I proceeded to tell her the story about how the logo came to be. Which, as you know, if you listen to the podcast and you see it on social media, it's about you have some microbes that are talking to each other. You have gram-positive cocci, gram-negative rods, and they're actually sitting on blood agar. So tune in to hear the story about the logo and definitely learn about macrolides and Lincosamides. As I like to say, all in all, such a great episode, very informative. So let's go ahead and listen to it. Well, by now, those of you that listen to the podcast constantly, you know that there's an AMR series where we talk about antibiotics. In the spirit of the podcast, we really break it down. And, by now we have gone pretty much, through most of the classes. And don't worry, once we finish this, the plan is eventually start diving into mechanisms and things like that. But in the meantime, today we are covering two classes. Those of you that work in the lab, in microbiology, you definitely have done a D test at some point in time. So you know about erythromycin and clindamycin. So we'll be going over those classes today. So, of course, with the AMR series, I'm always accompanied by my wonderful co-host, Andrea Princey. So, hey, Andrea, how are you?
Hey, Luis, I'm doing great. Happy holidays. We're almost through it.
Yeah.
I find them exhausting, to be honest, but
Yeah, I think in my case, I find the quiet refreshing before the next semester the teaching, starts again. And as everyone knows, no school right now. So it's kind of nice to just be working and then, podcasting. So
yeah. And you know what? I want all the listeners to rejoice with me in congratulating you in finishing your master's degree. I don't know if people know that happened. I'm really proud of you. I think that's really inspirational.
thank you so much. It's a great feeling, like I accomplished this and now I have this master's and it was hard work, definitely doing so many things at once. And of course, maybe there wasn't a need to do that many things. Like maybe I could have stopped teaching or not do this, which I don't think so. I love it. So I have to find another way. But no, definitely very, very worth it. And, walking through that stage and it was, so amazing. So I'm very happy that I did it. And I think it's not over yet. I'm going to consider and see if maybe look at other alternatives and see if I want to keep pursuing studies. So everyone stay tuned. But the audience, so wonderful, understanding about sometimes when I couldn't publish episodes and things like that. So thank you, everyone.
You're awesome. We're all cheering you on.
Thank you. And of course, but other than that, everything okay with you?
Yeah, just working like crazy, very busy. Also, always studying something. I think we're all kind of masochistic a little bit, right? Like we we take on more than we should. Like I'm still doing this master's certificate in additional research methodology stuff, and I don't know. I love learning, so that's why I love doing this with you. And anything that involves learning or helping others learn, I think it's awesome.
Well, definitely very happy to continue doing this. And of course, with this type of episodes, we always bring a guest, and we were talking a little bit about that. There's always wonderful guests. Right now, we have a perfect record, so this time is no exception, and we have a guest. So if you want to go ahead and introduce her.
Yes. Okay. So we were laughing because I was just telling Louise and our guest, I said, we're so fortunate because we always have the best people come on as guests. But I'm like, well, I think it's because we handpick like the most wonderful people. So it's amazing that we get to chat with like such bright, lovely people. And yes, today is no exception. So today we have Sonali Kalathiya. She is like a total class act. I mean, just a lovely human and bright as can be, and just like a delight to listen to. You're going to find that today. So, she received her Doctor of Pharmacy and Master of Public Health, yay, from the University of Kentucky before her PGY1 and PGY2 infectious diseases pharmacy residency at Grady Health System. She then served as the infectious diseases and antimicrobial stewardship clinical pharmacy specialist at Johns Hopkins Bayview Medical Center before transitioning to Loyola University Medical Center as a pharmacy clinical coordinator. She's now a medical science liaison at BMRU, lucky us, with a focus on rapid diagnostics. Sonali is passionate about increasing awareness and education around antimicrobial resistance and the role we can all play to better public health. Welcome, Sonali, and I'll give you a minute to say anything you'd like to say before we dive into the session.
Thank you so much, Andrea, and to Louise for having me on this podcast. I'm honestly like super humbled. I was just saying how awesome it is that that Louise is doing this amazing work with Andrea and really like spreading the knowledge of infectious diseases and microbiology, making it like fun, accessible, digestible, right? The more we know, the more we can do for our patients. And so I'm just really excited to be here. Thank you.
What a pleasure having you. So welcome to Let's Talk Micro. And this is something that has been said over and over again, but and I mentioned this, off camera or what I'm recording, but I love this. And even though no one will listen, I will be doing it still. But it's always great when I meet people that listen and they benefit somewhat from the product or they share it. So it's again, what can I say? It's all great. So definitely welcome to Let's Talk Micro.
Thank you. Thank you so much.
My pleasure. Okay, so as and maybe before we jump into the thing, because this is something that we talk about sharing, and no one has ever asked me what you asked me, Sonali. So maybe if you want to ask it in front of the listeners.
Absolutely. So I had to know, the icon when you pull up the podcast, Let's Talk Micro, it has like a group of bacteria. And I had to ask Luis, like, it's beautiful artwork. Did he create this? Where did it come from? So Luis has an amazing answer. I would love for him to share.
Yeah, and I wish that I could say that I created it myself, but my talents extend to microbiology and that's about it. And I have a lot of knowledge about film also, but anyway, so yeah, it was just one of those things when I was coming with the concept of the podcast and bouncing names, and then finally the name Let's Talk Microland, and then I was talking, and then we're so what can be the logo, and then like my wife suggested, it's like, okay, well, maybe what about a cocci and a rod, and she kind of put like a sketch on a napkin, and then I'm like, well, like this looks good, and then we asked someone, and they drew it for us, and supposedly it wasn't ready, but I really thought that like someone was gonna steal my idea of a podcast, even though I know that there's some great ones out there, but my specific concept, wasn't really out there. So I asked the person that said it's not ready, but it looked good to me, so I used it, I launched it, and here we are, 3 years later.
Amazing. And for those who haven't analyzed it as deeply as I just did, it's essentially a group of bacteria, gram positive, gram negative. They're talking at each other. They have big personalities. So go take a look.
Yeah, so there are two microbes talking, and they actually they are on blood agar. So that's the bottom of it. So it's amazing all this time, all these people, and no one ever said it. Why, what the logo, what's behind it. So it was great to hear this. So thank you for asking that. Okay, and for the audience, and I told you this when I was recording another episode. If you sound my voice, my voice sounds a little differently. I'm getting over a cold, so my apologies. I will try my best. So and we'll get through it. Okay, so we are talking about the macrolides and the lincosamide groups. So as always with this type of episode, we love a historical overview. If you have any to share with us, Sonali, so and also which drugs do these groups include?
Sure. So I'll start with the macrolides. So similar to some of the other drugs that you've talked about already on this podcast, it was discovered from a bacterial species called Streptomyces, and this one specifically was Streptomyces erythraeus. So it's found in the soil in the Philippines. That's where it was discovered. This is specifically erythromycin around 1952. And then when you look at the chemical structure of that, it's made up of a lactone ring with a few deoxy sugars. And so chemists made some minor structural modifications to this original compound that really helped with some of the issues that it was having with PK/PD, such as acid stability in the GI tract, tissue penetration, and then also expanding the spectrum of activity. So that's really where clarithromycin and azithromycin were formed. So those are semi-synthetic derivatives of erythromycin, and those were approved in the US around 1991. And then moving on to the lincosamides, kind of a similar story here. So isolated first, the first lincosamide was lincomycin, isolated in 1962, also from a Streptomyces, but this was Streptomyces lincomnensis. And this was found in the soil in Lincoln, Nebraska. So you can see where that name probably is coming from. Lincomycin is now rarely used. Its chemical structure is an amino acid and a sugar that's connected by an amide bond. But they, again, did some chemical modifications here to improve the pharmacokinetics. Some of these include GI absorption, half-life, again, tissue and intracellular penetration, and spectrum of activity. And so with that, clindamycin was approved, and that was in 1970, and that's really the only lincosamide antibiotic.
Okay, well, thank you for that. And As always, when we're going over this classes, knowing the mechanism of action is very important. So maybe, we can start with that and then progress as, maybe which organisms this group, treats and then jump to the question of intrinsic resistance.
So for macrolides and lincosamides, the mechanism of action is actually pretty similar. So the mechanism of action of macrolides is by inhibiting protein synthesis by binding reversibly to 50S ribosomal subunit. And that is similar to the mechanism of the lincosamides as well. So both of these are bacteriostatic. The spectrum of activity, though, between them differs, and also within the class of macrolides, there are slight differences. So generally speaking, macrolides cover gram-positives, so this includes staph, strep, although there has been high rates of resistance seen now with Streptococcus pneumoniae specifically. It also covers Haemophilus influenza really well, Moraxella catarrhalis, atypical organisms like Mycoplasma, Chlamydia, Legionella. Mycoplasma pneumoniae is also of particular importance currently because the CDC has reported increased rates of Mycoplasma causing infections recently. And then also non-tuberculosis mycobacteria, Helicobacter pylori, Neisseria. So just a whole slew of organisms that are covered by this class generally. Looking at resistance, there are a few different types of resistance that are seen. So in terms of intrinsic resistance, generally gram-negative bacteria like Enterobacterales, Pseudomonas, Acinetobacter have this intrinsic resistance because of decreased permeability of the outer cell envelope. But there are also some forms of acquired resistance that are really relevant. So there's a gene called the erythromycin ribosome methylase gene, or the ERM gene. So this methylase modifies the actual target site on the bacteria. And by modifying it, it decreases the drug binding. And because, again, macrolides and lincosamides share that same ribosomal binding site, expression of this enzyme can lead to cross-resistance between these two classes of drugs. And so I'll discuss more below when I get to clindamycin, but really, really important form of acquired resistance there. And then also efflux pumps. So those are what's commonly seen in staph and strep.
And I don't want to put you on the spot here, Sonali, but you said something interesting, and I think for the laboratorians that are listening, this would be meaningful. So you talked about this bacteriostatic activity, right? And I think in the laboratory, that means one thing to us, but can you just briefly explain what you mean by that from an ID pharmacist perspective? What does the bacteriostatic mean?
Yeah, absolutely. So broadly, when you think about bacteriostatic drugs, it means that you're preventing the growth of bacteria. And compared to bactericidal, that's when you're actively killing the bacteria. So those are like general definitions. And really in the lab, it's determined in vitro. You're looking at the minimum bactericidal concentration compared to the minimum inhibitory concentration. And if it's greater than 4, it's considered bacteriostatic. But realistically, clinically, it's a little bit more murky. So bacteriostatic antibiotics are still killing the bacteria. They just require a much, much higher concentration. And when they have done a few studies that compare bactericidal agents versus bacteriostatic agents versus bactericidal agents, they haven't necessarily been proven to be more effective than bacteriostatic agents. And there's a number of other factors to consider here, such as like dosing of the antibiotic, making sure you're optimizing your PK/PD and host factors. So I think it's a lot more complicated when it comes to the clinical applicability here, but those are broadly the definitions.
No, that's so helpful. I always learned, at least from the laboratory side, like these bacteriostatic drugs, we're going to kind of do this initial work and keep things, like you said, at this lower level so that the body could come in and clean up the rest of it, or if there's another agent or something like that, that could help kind of finish the work and prevent it from doing any further growth or damage or whatever. And the reason I bring this up is because in the laboratory, when we're doing susceptibility testing on drugs that are bacteriostatic, especially if you're doing like a gradient diffusion or like e-test, it can be really, really challenging to read these zones of inhibition because the bacteriostatic ones won't completely clear the growth where the MIC hits. And so I just always like to mention little nuggets of info for any laboratorians on the call, just because, for example, if you're reading an e-test with a bacteriostatic drug, the recommendation is going to be like, read the MIC where the growth is inhibited at 80%. And you can imagine how eyeballing 80% can be kind of hard, right? So I don't know if clinicians are aware of this either. There's a whole different approach to, manually reading susceptibility test results for drugs that are bacteriostatic in the lab. It's just something that I think is interesting to note. So thanks for bringing that up.
Well, and thank you, Andrea, that you were mentioning that in the lab about bacteriostatic and bactericidal, because that's something that it can definitely be a little daunting when you're learning in the lab, and like you're following your policies and you're learning, okay, this one is bacteriostatic, and then this one have to read 80%, and this one at 100% for the bactericidal. So it's keeping those concepts together. It can sometimes be a little bit challenging, especially when you're learning and getting all this information at once on the bench. Okay, so then what about for lincosamides?
Yeah, so for lincosamides, the mechanism of action, like I said, is similar. So it inhibits protein synthesis by binding to that 50S ribosomal subunit. But the spectrum of activity is different. So clindamycin is primarily for gram-positive organisms. So this includes strep, methicillin-sensitive Staph aureus, as well as some methicillin-resistant Staph aureus, although there is quite a bit of resistance to clindamycin occurring here as well. It also covers anaerobes, and especially gram-positive anaerobes, so Peptostreptococcus, Clostridium perfringens, the acnes, actinomyces, and traditionally it's thought of as covering the anaerobes above the gut, above the diaphragm, so not including the gut. And that's because gram-negative anaerobes such as Fusobacterium, Prevotella, it covers those. But especially when you look at things like B. fragilis, there's rapidly increasing resistance there. And so it's definitely not as reliable for B. frag as it is for like some of your more gram-positive anaerobes there. And then others that include Pneumocystis jirovecii and Toxoplasma, among some others as well. So some very niche organisms here. And then when you're looking at resistance for lincosamides and clindamycin specifically, again, intrinsic resistance is primarily your aerobic gram-negative, so Enterobacterales, Pseudomonas, Acinetobacter, and again, this is because of poor permeability of the outer envelope, and then also efflux pumps for Enterococcus species. So clindamycin is not effective for Enterococcus. So moving back to that discussion about the methylase enzymes and resistance there for the macrolides. So again, it's the same target here for clindamycin, although clindamycin is not actually inducing that resistance that the macrolides are. So it kind of was reported when there was increasing treatment failure in cases where clindamycin was used for example, an MRSA for strains that appeared to be sensitive or susceptible to clindamycin, but were resistant to macrolides. And then when they went back and retested these isolates, they found that clindamycin had actually become resistant. And often in these cases, there was initial improvement on clindamycin and then clinical worsening, maybe days or weeks into completion of therapy. And so what is thought to be happening here is when you have that ERM mutation, it can turn this inducible resistance to constitutive resistance, and using clindamycin leads to emergence of resistance during your course of therapy. And so that is where you might have heard, or I'm sure you've heard of the D-test, where you put erythromycin and clindamycin discs on an agar plate with your organism, and then you look for a blunting of the zone of inhibition. So where the erythromycin meets the clindamycin, the organisms are growing there. And that signals to you that there is inducible resistance present there, and using clindamycin might lead to the emergence of resistance during therapy or therapeutic failure. This is definitely more of a concern for like serious invasive infections, and CLSI actually has a comment in the M100 where if you test an isolate that's erythromycin resistant and clindamycin susceptible, then you should do the DEES test to test for this inducible clindamycin resistance before reporting your susceptibility to clindamycin.
This is great, Sonali. It's such a good point, and I'm sure, the folks listening are all aware of this, but it's just another really important point to drive home that, in our labs, you might see various forms of this kind of inducible clindamycin resistance testing. So certainly when I was in the lab, we primarily did it manually. We set a D test on pretty much every Staph aureus or group A strep that we were testing, like at minimum, but there were other beta hemolytic organisms we would consider doing this with. We would always do that before we released the clindamycin results. Some sites, now certainly there's inducible clindamycin resistance testing on our automated susceptibility testing panels or cards or what have you. But the bottom line, to your point, is that we really shouldn't be releasing clindamycin results if erythromycin is resistant. We see that pattern, and some sort of D-test type inducible clinda test has not been performed, just because we can't really rely on that susceptibility result for clindamycin. If we don't understand what's going to happen with that pattern, it could end up leading to, failure of therapy or treatment or anything like that. So great point. I'm so glad you bring it up. And that kind of is a nice lead into my next question for you, which is about picking, one drug over another. So let's just start with macrolides, since we're doing two different groups here. So we've got in the macrolides, like you said, we've got erythromycin, clarithromycin, and zithromycin. Why would a clinician choose one of those over the other? And I think from a laboratory perspective, erythromycin, we're always testing it, but we're like, is anybody actually using this in real life? Or are we just running this so that we can make sure we've got D-tests happening and things like that? So I think it's helpful for us laboratorians to understand why you would pick one of these over another.
Yeah, great question. So generally, as a class, macrolides are very widely distributed into tissues, except for the brain and CSF. So that is why we don't use these typically for the treatment of those types of infections. There's also a small amount excreted unchanged in the urine, but primarily it's metabolized hepatically, so also not really used for like urinary tract infections, for example. But when you look specifically at each individual drug, I'll just start with erythromycin. I mentioned earlier that it's inactivated by gastric acid. There's a lot of issues with PK/PD. So because of that and the effect on absorption, you have to do like enteric coating. There's also high rates of GI distress, so it's harder to tolerate than some of the other macrolides, so nausea, vomiting, diarrhea. But actually, the activity stimulates GI motility by acting on motilin receptors. So this is kind of like a side effect of this medication. It's actually used sometimes as a prokinetic in the setting of gastroparesis to promote gastric emptying. So they're actually using this adverse effect to treat gastroparesis. It also has a higher rate of hepatotoxicity, some drug interactions, being a CYP3A4 inhibitor. So it's not used super often when you're comparing to drugs like clarithromycin or erythromycin. Clarithromycin, you might commonly see it being used in like peptic ulcer disease by H. pylori when you're combining with a proton pump inhibitor and amoxicillin, also for like disseminated mycobacterial avium infections. But primarily, I would say the star of the show of this class is really azithromycin, and a few different factors lead to that here. So very extensive tissue distribution with azithromycin, where you're getting really high concentrations within cells, including alveolar macrophages, sputum, lung. So really helpful for like pneumonia. Also, it has a really long half-life, so about 70 hours, which is unique for this drug when you're comparing to maybe like 3 to 7 hours for like clarithromycin, or even shorter for erythromycin. And so because of this long half-life, your dosing frequency can be every 24 hours. Whereas for erythromycin, clarithromycin, it's more like Q6 or Q12, respectively. So I think dosing frequency is one factor here. And just to kind of put that into perspective, because of that tissue distribution and the long half-life, 3 days of treatment with azithromycin provides coverage for 8 to 10 days. So really significant here. And again, that's unique for this specific drug. For like things like Mycobacterium avium prophylaxis, it's used like 1,200 milligrams once weekly for sexually transmitted infections like chlamydia or Neisseria. In the setting of penicillin allergies or pregnancy, for example, it's only a single dose. So it's really, really convenient for a lot of these disease states, which leads to its frequency of use here. Also, tolerability is a concern with some of the other ones, like I mentioned previously. So azithromycin tends to have less GI side effects as well as less drug interactions. And then also unique to azithromycin is its anti-inflammatory properties. So I think this is super interesting. I believe it might be related to like interleukin A, TNF alpha, but basically it has some anti-inflammatory properties where, for example, in treatment of community-acquired pneumonia, even though you're seeing those high rates of strep pneumoniae resistance, the combination treatment with beta-lactam is beneficial. It's also used, for example, in chronic treatment in COPD in patients chronically infected with Pseudomonas, again, for that anti-inflammatory effect. So this is totally separate from its antimicrobial properties here. And then I didn't mention, but as a class in general, you can have some QT prolongation, which especially if you're already at risk for QT prolongation because of, electrolyte abnormalities, being on other drugs that cause QT prolongation can lead to cardiac arrhythmia. So those are just a few things, within the class and just as a class in general that would kind of lead you to choose this class of antibiotics or a specific antibiotic compared to another.
I always tell Louise every time we do this, I'm like, I learn something crazy every time. Like I had no idea about these seemingly obscure side effects that that are actually things that we're like shooting for with this drug, like the gastroparesis thing or the anti-inflammatory properties with the Zithro. I had no idea. That's really interesting. And I think, Sonali, could you tell us, because I'm sure a bunch of listeners, probably most of them have received this antibiotic before in a name that is more common. They might be familiar with it. I don't know if you're.
Yeah, Z-Pak, right? So a lot of times in outpatient settings for respiratory tract infections, Z-Pak, Zithromax are the common brand names that you're probably hearing.
Yeah, I know y'all have gotten a Z-Pak. Everybody and their brother's gotten a Z-Pak. Luis, do you have a Z-Pak right now with your cold? What's going on?
No, but I actually, when we started doing the prep for this episode, immediately, memory came to mind. And this was about 2003. I was, serving in Parris Island, South Carolina, where the Marines do their boot camp. And I was a medic there. And one of the things I remember seeing was the Z-Packs and how frequently people gave them to each other. And we will tell the Marines, hey, like you have a cold, maybe come get seen. And they're like, no, I'm good to go. Just give me a Z-Pack and I'll be good. And people will give it to them like that, and they will not get seen. So I do remember a lot of Z-Packs around. So it definitely jumped to mind.
Yeah, that's why I wanted to mention it because I'm like, I'm sure people are going to hear the word Z-Pak and be like, oh, yes, 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 yes. Okay,
Lots
so
of Z-Paks going around right now, I'm sure.
yes, I know. Too much Z-packing happening. Okay, so same question, but we have a much shorter list here. So I think for the lincosamide group, maybe just to focus on why you would use this at all or what the benefits are.
Sure. So with clindamycin, also widely distributed in fluids and tissues, including bone, excluding CSF. So again, important to consider if you have a CNS infection there. But the main adverse effect with clindamycin is its antibiotic-associated diarrhea. And this can include C. difficile colitis. So what's happening here is because clindamycin has such a broad activity against your anaerobes in your gut, it really disrupts your microbiome and leads to overgrowth of Clostridium difficile. And, the toxins that it's producing can damage your epithelial cells, leading to inflammation, diarrhea, which can be very severe and recurrent. So it's a big concern, not just with clindamycin. This can be seen with any antibiotic really that's affecting your gut microbiome. But it is a concern specifically with clindamycin. And so a lot of times combining this adverse effect with the increasing resistance that we're seeing, it's really fallen out of favor when you're comparing it to something like a beta-lactam, which is much typically safer and more effective. So when you are seeing clindamycin being used, oftentimes again, staph and strep, specifically if you have a severe penicillin allergy, which I know you, with Dr. Brian Rao, you talked about testing for that and making sure that it's actually an allergy and not just like an intolerance or an insensitivity there, because beta-lactams tend to be more effective. But if you do have a severe penicillin allergy and you're treating staph or strep infection, then clindamycin can be effective here. Also unique to clindamycin is its effect on toxin production, specifically for bacteria such as strep pyogenes. So strep pyogenes or group A strep can cause necrotizing fasciitis. And what's happening here is the bacteria produces a toxin that destroys your fascia or your connective tissue beneath the skin that leads to tissue necrosis. And, the characteristic sign of neck sash is this pain that's kind of out of proportion to the visible changes that you're seeing. And so it's been shown that clindamycin can really reduce that toxin expression and therefore help with treatment when you combine it as an adjunct to a cell wall active agent like a beta-lactam. So those are kind of like a couple of the niche areas where you can use clindamycin. Also, bacterial vaginosis. It's used in pneumocystis pneumonia. If you have a severe sulfa allergy, in addition to primaquine, and then toxoplasmosis as well, if you're unable to tolerate sulfadiazine, in addition to pyrazinamide. So again, a few areas here where you would reach for clindamycin. And then another one that we're not really seeing as much inpatient, but outpatient prescriptions, like things like acne, there's like a topical product that can be used. So yeah, a few different outpatient applicabilities of clindamycin as well.
It's such a good example of how, of course, antibiotics are a savior for us in so many ways, but also completely not benign, right? Like clindamycin is, unfortunately, I've had to take it multiple times in my life. I have, an underlying condition where I get soft tissue infections a lot and all sorts of things like that, and have been plagued with a beta-lactam allergy my whole life, which I have yet to have removed. And so I, from personal experience, can say it's like it's a rough drug. It feels like maybe an easy thing. It's an oral option, and it's maybe something that feels accessible for someone like me. But honestly, I have the side effects are pretty rough. So I mean, I certainly see its utility, but I think it's a good example of how rough these can be and not benign, especially to our guts and our digestive tracts. It can be really, really rough.
Yeah, absolutely. And yeah, I think it's super important to take that into consideration, right? When you're deciding about prescribing a drug, is even if it's effective, if you have a side effect that's really going to make your patient miserable, then it's definitely worth taking into consideration, and oftentimes leads to us, again, choosing one drug over another for these types of infections.
Well, thank you for that amazing description. And once again, to echo a little bit of what Andrea said, there is so much that I learned from this type of episodes and chatting, especially with with pharmacists, and that the detail that they provide. I don't know, it's great. I was recording the other day something about beta-lactams, and the explanation and everything. I have learned so much. So and we're gonna talk a little bit about breakpoints and things like that. But I want to take a moment to once again direct the techs that are listening, and definitely get familiar with the CLSI and the resources, and and the Appendix B with the intrinsic resistance and things like that. I remember not too long ago I saw that we had a request for erythromycin on I think it was like an E. coli. And I remember, I sent on the request, and then I went and, I talked to the tech and we chatted. But it's one of those things that sometimes, if you're not aware, you end up performing the test and then you end up releasing the results. So I definitely invite you to get familiar with the resources. Okay, so this is a question that I always like to ask, and and from my experience, typically in the lab, we have done testing. We do testing for erythromycin, clindamycin. I haven't done testing on azithromycin, but if we get a request, let's say for example, for like azithromycin, but we have the susceptibility results for erythromycin, can we apply that to that other drug in the class? And does that apply to the lincosamides as well? So basically my question is, so can we apply the interpretation of one member of the group to another?
Yeah. So for macrolides, specifically for strep, the CLSI M100 actually calls out that susceptibility and resistance to azithromycin and clarithromycin can be predicted by testing erythromycin. And so that's probably commonly what labs are doing, is just reporting one. For other bugs, that's not necessarily the case, especially when you're looking at the expanded gram-negative coverage with azithromycin and clarithromycin that you likely don't have with erythromycin, like as I was mentioning for like H flu, for example. And so in that case, you wouldn't necessarily be able to extrapolate the results from erythromycin. And then for lincosamides, it's really just clindamycin that we're currently using anyway. So there's not another drug.
And this is great. To Luis's point, we always really encourage people to be familiar with the M100. So if a clinician calls the lab and you have MICs and interps available for one drug in a class, double check to see if they're asking for something that hasn't been tested, if there's somewhere you can direct them in the M100 to help guide whether you can predict susceptibility for another drug in the class or not. And always don't make that assumption, because as you can see here, that's not always the case, right? So while we're talking about the M100, we always ask about breakpoints. If there are any recent breakpoint changes we should know about. I know macrolides and lincosamides aren't the ones we're usually thinking about a ton when we're thinking about major breakpoint changes or the impact there. There's some other classes where this has been obviously a huge issue. But is there anything in recent years that we should just be aware of with these two?
Sure. So for lincosamides, there really hasn't been. For macrolides, so specifically for azithromycin, there's been a few changes or additions, I should say, in the M100. So in 2021, for azithromycin, there was the addition of MIC for Shigella specifically, whereas previously it was just assigned an ECV. And then when you're looking at Neisseria gonorrhea, there was also the addition of MIC where previously it was an ECV and then also like a disc diffusion cutoff.
That's great. I don't know how many folks are doing this testing in-house. I think you said, Luis, that you do not for Zithro, right?
Correct. Yeah. So right now, basically, we do have so erythromycin. It's part of our Haemophilus disc panel, and then we have the AST cards for like the 75 for gram positives, and so that one has it, and then we have gradient strips for also. But as far as only erythromycin and clindamycin. So I have in any of the labs that I have been around, I haven't done testing on azithromycin.
Yeah, me neither. I think this is a great point that you bring up, Sonali, here with the ECV. And this was in, I think, gosh, one of our episodes we did a long time ago, Luis, on breakpoints specifically. I'll just do a really, really quick reminder of what that means, where the updates that Sonali just gave us were actually really interesting and helpful. Just a reminder to everyone that ECVs are epidemiologic cutoff values. So those are essentially MIC distributions of a bug-drug combination in early testing. And while it's really informative and you can kind of divide this distribution into wild type susceptible organisms and those that look like they might be resistant, that's not like a breakpoint by itself. So the ECV is what's used as like a starting point to determine a breakpoint for a bug-drug combo, but ultimately we need lots of clinical data and pharmacokinetic, pharmacodynamic data in combination with the ECV to eventually get a breakpoint for MICs. So I just mentioned that because sometimes we'll have ECV and people can maybe, use that to guide clinical decision making and things around susceptibility testing. But it's really helpful when there's MICs and interps for those MICs, because usually that means there's been more clinical data and we can maybe make a little more sense of it. So it's just a really good point. And I like to kind of give that refresher just because I know that like breakpoints and ECVs and everything can get a little bit confusing. So it's a great point. In terms of testing in the lab, since we're kind of segueing into that, do you have any comments in addition to what maybe you've already mentioned with respect to how we should be testing for these drug classes in the lab, or any key points we might want to keep in mind?
Sure. So I think, as I've kind of mentioned, the M100 is super, super helpful in kind of helping labs determine some of these. And I'll just point out a few things that I found there to be really helpful. So for macrolides, they specifically call out that they shouldn't routinely be reported for organisms from urine specimens. So that's really relevant, and I'm sure labs aren't reporting those for urine specimens there. For H. flu, specifically, susceptibility testing for erythromycin is often unnecessary. It's typically covered by erythromycin, and you're most likely testing for other beta-lactams initially, at least. It makes a comment about salmonella and shigella and potentially using cascade reporting before reporting azithromycin. And then when you're moving on to things like Neisseria, gonorrhea, again, typically you're not testing. I'm curious to hear from you all if you've seen that being done routinely, but usually you're only culturing and testing if you're seeing treatment failure, not empirically off the bat. So there's just a few other comments in there that I would encourage you all to kind of take a look at. For lincosamides, it does really focus on that testing for inducible clindamycin resistance. Typically, susceptibility testing of group B strep does not need to be performed routinely, but it does specifically call out that if you are considering clindamycin for like intrapartum prophylaxis, like a pregnant woman with a severe penicillin allergy, then you should do this testing for inducible clindamycin resistance. Definitely for like staph, as we've mentioned previously, because of the high rates of resistance that we're seeing with clindamycin, it's helpful to test to make sure that it's going to be effective against your staph species. So those are just a few points to consider.
This is great. And I think I would highlight here that this is also just a reminder that we don't, especially with drug classes like these, right? Like, it is not necessary to report MICs and interpretations for every bug drug combo all the time. And so that's why you'll see rules built into automated susceptibility test systems that do this work for you behind the scenes, or maybe you're manually building rules into your LIS system, or that's a double LIS into your LIS, that helps support this kind of thing, right? Because, for example, Sonali asked about, susceptibility testing on Neisseria gonorrhea. When I was in the lab, I certainly never did that in-house. If a patient wasn't doing well and then they wanted that follow-up, we could send it out. It was kind of a case-by-case situation, and that's really the best use of resources. And so it's really nice when you have these kinds of guidelines and something like M100 that you can build into your workflow in the lab, to ensure that you're not, overdoing these things or missing something like testing for group B strep in a pregnant patient. We had a whole algorithm built around that where we would, consistently set up a certain panel of drugs for that specific subgroup of patients and would be aware of those specimens when they came in. So it's just a really important reminder of these, like, clinical utility and then laboratory applicability, and how you can fit these things in your workflow, and how essential that CLSI guidance is. And Luis, I don't know if you have anything to add about that for your workflow, or just thoughts there.
No, I mean, like you said, when we have all these rules, and then maybe those on the audience that when you are, let's say, looking at the Vitec and some of these cards like the AST for gram positives, and it tests for the ICR, and so if it's positive, it will change the interpretation for you. So it will call the clindamycin, resistant, and then you still have to review and accept before it crosses over. But definitely, things like that, and that is all I have to say. I mean, particularly in my lab, I think until recently we were only doing testing on, like, susceptibility testing on group B strep cultures when the patient, like, they specify in the form, like when they ordered the test on the LIS, that there was an allergy. Other than that, we will release the organism, and that's it. But other than that, I don't have anything else to add.
Yeah, that's great. I just think it's, I think we have so many things at our fingertips. Sometimes it's easy to forget that the value of cascading and things like that, that it's not always resource appropriate or necessary to just test everything all the time. And this is such a great example, right? Like, it's only needed in certain situations. And how infrequently we actually are doing in a lot of labs testing for something like azithromycin, but it's used all the time, right? So just kind of thinking about how that all plays out in real life. It's really great, Sonali. Thank you.
Thank you, Sonali. And and before we kind of start wrapping up the episode, is there anything else that you want to add or tell the audience about?
No, thank you. Thank you, Luis. Thank you, Andrea. I so appreciate the opportunity to be here and contribute in a small way to this amazing work that you both are doing. So thank you again for having me.
That's our pleasure. Thank you.
Then definitely, and definitely you contributed a lot, and it was like you gave us a lot of great information. So thank you so much. And what about you, Andrea? Do you have anything else?
No, just, I just always am so grateful for the folks that are willing to take the time to come on here and share knowledge with others. I'm really, really grateful. And as always, Luis and I always like to highlight the collaboration between clinical partners and laboratorians. I think it's something we should continue to emphasize as our landscape changes in infectious diseases, and it's more important than ever. So I just love when we have, ID PharmDs or ID, MDs or other clinicians come on here and talk to us and, present things that are meaningful to the laboratory community and beyond. I think it's just really special. So thank you again so much.
I completely agree, and we all benefit from this type of episodes. And once again, Sonali, thank you so much for taking the time to be in Let's Talk Micro. And that, my dear audience, it's the end of this episode. I hope you enjoy learning about the macrolides and lincosamides. As always, I enjoy sharing this information with you. So please, continue bringing that passion to what you do. It's so important. You do such great work. And if you haven't listened to the previous episodes of the AMR series, please go ahead and check them out. By now we have done all the major drugs, all the major groups. We started with beta-lactams and worked our way. So great episodes, so check them out. And while you're at it, check other episodes. Thank you so much for the support. Great things coming your way. So, as always, stay motivated, stay safe, and of course, Sonali,
Continue talking micro.
Continue talking micro. Until the next time. Bye.